Hey guys, welcome to another episode of DarshanTalks. My name is Darshan Kulkarni. I hope to provide help in a way that I can help patients trust the products they depend on. So I'm an attorney, I'm a pharmacist, and I advise companies with FDA regulated products. So if you have an interest in FDA regulated companies with their products, this is the podcast for you. So today's podcast is actually going to be something slightly different. We normally do like a little bit of prep before we jump on, and it's usually about 5 minutes before the actual conversation starts. And I thought it might be more fun for some people to go, "Oh, this is how you come up with the topics," and you're going to see it happen live. So if you are um, in the reimbursement world, if you are a pharmacist trying to figure out how is reimbursement determined, if you are a pharmaceutical company going, yeah, how do I position my product so that someone will pay for them? If you are a new health tech company and you're going, is someone going to pay for this? This is probably the conversation you want to be listening to. Our guest today is, I believe it's Mr. Kenneth White, but I could be wrong. I mean, technically, with the Juris Doctor, I should be saying Dr. Kenneth White, but I think most bar rules prevent us from calling ourselves doctor. So,
That is
ladies
correct.
and gentlemen, our guest for today, Kenneth White. How are you?
And I don't look like an Esquire, so we can't put that on there. How's it?
I don't
What's going
know.
on? It's good to see you again.
Good to see you. You've been busy, so tell me more about what you've been doing with COVID. How have things been? How have, for example,
Wow.
EUA been treating someone like you in the insurance world?
So
So, so
it's been interesting because my first 30 years in the industry was as a healthcare lawyer, which I
Mhm.
am still a healthcare lawyer. But as a trial attorney, and you watched all the trials come to a grinding halt, and you watched you know the way that they had to do those things very, very differently. But 7 years ago, I jumped over to Willis, now Willis Towers Watson, as the head of their managed care practice. So um, mostly what I do is keep people inside my company and exterior to my company advised on all things managed care, and that's a big bucket managed care, not just the traditional companies like Humana or Aetna or the Blues. Um, and I spend a lot of time on what most people would refer to as sales and retention, and a lot of that flips over to claims, coverage claims, manuscripting insurance policies for risk related. So a lot of what I do would have been done via an airport and an office somewhere else. During COVID, it's all been this way, on a phone, on a computer, whether it's Teams or Zoom, or Skype, or any of the other platforms that people use. And we've actually found that it works pretty well. There's no I wouldn't tell you that it substitutes for personal contact. It doesn't. But when you are forced to use this, it has not been very problematic for actually getting the work done. It's just difficult on personal relationships, meeting new people. You and I haven't seen each other in over a year, and yet we would normally have seen each other probably 3 or 4 times during the course of the year, either when I was in Philly or if we had ABA events where we were both attending. So, that part's not very good. But work related wise, it hasn't really caused us to miss a step.
so Kenny, this is where there's so many questions I can delve into, and I'm going to start with a few basic ones. Um, what does the head of a managed care practice do? And you said big bucket managed care versus a Humana or a one of the Blues. How did you? What is the distinction? What does that even mean?
Okay, so most people consider managed care organizations or MCOs to be those with payment responsibilities,
Mhm.
a health plan that has to pay out for benefits, whether that's health or dental or vision, pet insurance, whatever it is. There's an obligation to make a payment. That could be a self-funded health plan. It could be a fully insured, employer-based plan. It could be a tribal plan. It could be anything offered by CMS, Medicare, Medicaid, TRICARE, VA, government employee health benefits, any of that stuff. but it also covers provider-owned health plans, entities that are traditionally hospitals or health systems, or even very large physician groups that offer a health plan, such as a Medicare Advantage plan. Um, uh, the largest of those are like Kaiser Permanente, which is an entity that has both, but many health systems also offer a smaller version of a Medicare Advantage plan if they have a good rep in a given geography so that they can market it. The bucket also includes entities like MSOs, or medical services organizations, that provide administrative support and downside risk financing for provider organizations, entities like accountable care organizations through the federal government, or commercial health plans. And then provider organizations that enter into value-based contracting for because they have a lot of what you would think of as a managed care obligation delegated to them through their contracts. And then you have PBMs, or pharmacy benefit managers, of all walks and shapes, from the full service things like Express Scripts, Prime Therapeutics, OptumRx, Caremark, those entities, all the way down to an entity that doesn't do much of anything other than provide consulting on formulary decisions. So you've got the whole gamut. My responsibility sort of ends at the far side of PBM. So once you start getting into retail pharmacy or pure pharmacy distribution or manufacturing, that's all in life sciences.
So a few different questions pop up from there for me. The first one is, we talked about PBMs a few seconds ago. Why is there no such thing as a medical device benefit organization? Like, PBMs control which prescription which drug is appropriate, and they can be expensive for sure, but so can medical devices. Why has that same level of control not been placed on, say, which heart monitor to use, or which insulin glucometer you should be able to get? Was there a thought process behind it, or is it just how it evolved?
I think it's just the way the industry has grown up. First of all, the DME and medical device industry has a number of very well-funded lobbying organizations that spend a great deal of time and effort lobbying on their behalf. Two, the medical device industry is pretty heavily regulated by the FDA, and providers or payors. I separate everything into provider and payer. If you're a physician or a hospital or an ambulatory surgery center, you're a provider. If you're a health plan, you're a payer. So
Right.
the payors will list out things that they will provide or pay for, but most of the time it stops at experimental items.
Right.
Also, medical devices fall into two categories as far as I can tell: those that are unique and you only have one or two options, or to those that are being ordered by a provider for a specific purpose. So hip
So
joints,
glucometer.
prosthetic hip joints.
Okay.
I mean, the market itself will shake out whether or not, you have a decent hip replacement prosthetic.
Mm-hmm.
You have a few that go bad on you, or the FDA doesn't give you authorization to sell it. There's not 150 entities out there making prosthetic hips.
Yeah.
You don't have that many, and a physician is going to order one or the other, hopefully based upon the medical need. And as long as it's not something way out there that's considered experimental, then the health plan is going to pay for it. They oftentimes, with the larger entities, will have contracts with those entities to purchase the prosthetic devices and things like that at a discount, just like
Mm-hmm.
they do drugs.
Yeah.
But then you have the whole DME industry, the scooters, you too can get an electric scooter and Medicare will pay for it, and you know, you may not need one. You never thought about needing one. You're perfectly mobile, but since this company at 2 o'clock in the morning is advertising that they can get you one through Medicare for free, why not? Because
Right.
they're fun to ride around
Your
the
voice is
Publix,
really great for
with
that.
somebody, yes, somebody, there ain't no such thing as a free lunch, Darshan. You know that. The Tonstoffel principle is alive and well. There ain't no such thing as a free lunch. Somebody's paying.
But here's the thing: you talked about, as you said, the DME industry versus the one-offs, if you will, for lack of a better term. And in those specific instances, you said, well, you hope the market will bear itself out, and sort of depending on the market to do that. But that same analysis doesn't apply to prescription drugs, even though you could make the exact same argument. There are 15,000, well, I'm making that up, 15 different blood pressure medicines. And we're going, no, we're going to control exactly how you choose which one and how you go down the pathway. But you don't do the same thing for glucometers, where there are 15 different glucometers. You're like, well, we believe the market will bear itself out. Why the distinction, even though they're both FDA regulated? They're both, hopefully the market will bear themselves out as well.
Odds are that the prices of the glucometers are all within a relatively small range of prices. And you could go online right now and find out how much every single one of them costs.
So the lack of transparency.
Try to do that with the blood pressure medication.
I love it. So the price transparency has come back to hit pharmacies, and that's really where that's a really interesting argument. Never heard that. Let me ask you.
We have never, ever, ever, ever wanted to believe anything other than you get what you pay for in healthcare.
Yeah.
So we think that the surgeon that charges $100,000 to do X is better than the surgeon who charges $20,000 to do X, when that may or may not be accurate.
Yeah.
Same thing with drugs. I mean, insulin is insulin. An EpiPen is an EpiPen. Why is the EpiPen at $500 better than the EpiPen at $25? It's not, because the EpiPen is an EpiPen. And if the medication on the inside of the auto injector is the right kind of medication, then it's going to work just like the $500 one does.
Well, I'm going to call you out on that a little bit, because I think the reason that thinking maybe gets adjusted a little bit is in the context of compounding. So that
the drug has to be the right drug on the inside.
Right. But the thing is, in the compounding industry, they aren't held to the same standards. They're held to pretty high standards, but they're not held to the same standards as a product that goes through an NDA process. And therefore, there was a company that was trying to, I'm blanking on the drug, but essentially they said it's too expensive. Fine, we'll compound it and we can give it to you as well. And it'll be 1/10 the cost. And I can see the logic behind it, but I worry in those scenarios if you're asking for trouble. But that's just
the same thing with generics. I mean,
but they're still going through an NDA process.
Why are Canadian generic drugs to be feared? Right. I mean, I've known them. I know a lot of Canadians, and most of them are very nice people. Except during hockey season when they can be a little rough. But I mean, you're in Philly, so you should understand that. But I mean, I don't. There is an irrational fear, I think, of some drugs because of where they come from, but that's not the real reason. It's the lobbying over a drug made in India or one made in Canada, or exported from the U.S. to Canada and then not being able to be re-imported in because apparently the Canadians did something to it. So, but I mean, it's so the pharma industry can charge us what they charge us for drugs versus what they charge people in France for drugs.
So let's raise another question that actually came up, and I had a little bit of a discussion about it yesterday, but I don't know anyone more qualified to answer it than you are. And the argument was, why don't we have more physician-owned managed care organizations where they have their own population? So think value-based care, but really owned by physicians. and my initial and the argument there was, well, this is going to be great because physicians would be responsible for the care of the person, and if they didn't save money, they would make no money, and they're incentivized. Um, but my argument is that's why we have the Stark Law, which is people, just because they have the incentives doesn't mean that they aren't going to milk the system if they can. And one of the people I was talking to responded that, well, that's not necessarily always true, and you're not thinking like the one that really threw me off was when the individual went, healthcare fraud doesn't exist in the same way you think it does. I was like, okay, I'm not sure I agree with that statement, but I think you're ideally placed to talk a little bit about what is your opinion on physician-owned managed care.
Um, the opposite of Nike. Don't do it.
Why?
There are a lot of reasons, but the primary one is physicians and people in corporate healthcare have different objectives. If we assume that most physicians or healthcare providers of any type, didn't just join their profession in order to have an expensive Mercedes, then they think differently than people who have to watch the bottom line. And when you are in the insurance industry, whether or not you call it managed care or whether you call it straight indemnity insurance, there is a different mindset with regard to how that works, and the two don't mesh very well. The other part is that it takes a very different set of skills. You're a physician, you're a pharmacist and a lawyer. Okay, so how many doctor lawyers did you come into contact with? I've known a number of them.
Me too.
A few of them were excellent at one or the other.
Yeah.
One or two of them may have been very good at both.
Yeah.
Most of them were average at both.
Okay, fair enough.
Because it's a different skill set
Yeah.
to be a physician and to be a lawyer.
Yeah.
To run a physician practice, those that are run the best usually have an entire array of administrative personnel that are not physicians, that are MBAs and accountants and lawyers that run the show from a corporate perspective, particularly the larger entities, and it's better to do it that way. And the next thing is a matter of money.
Okay.
A health plan has risk.
Right.
You collect premiums, you pay for health care.
Right.
That has to be done in volume in order to be able to do it well.
Mm-hmm.
It takes a great deal of money to do those things. Let's say United Health Group. We'll just take the big boy on the block.
Sure.
United Health Group 2020 revenue is probably closing in on the $300 billion mark.
Whoa, okay.
Now, half of that is non-premium dollar income. But yeah, like Optum, all the Optum stuff is not premium dollar. So Optum RX, which is their big PBM, isn't considered in the premium dollar. But on the premium side, you have the MLR, the medical loss ratio, that has to be met. So, if you have a company that's got $100 million in premium revenue, they have to pay out 80 to 85 million, depending upon which product line it is, in benefits, or they have to return the money, to the people that paid the premiums in. So, that kind of revenue and that kind of margins where you have to provide all of the administrative services within a narrow thing, yes, these companies make a big profit when you look at them by way of dollar figure. But in terms of historic, as opposed to last year, historic profit off the actual premium dollar side of the business has been generally 5-6% at most. And that's not something that most physician practices of any size would be able to handle, because if you have a couple of downside outlier claims, it's the same thing with running their own health plan. I mean, if you have a physician group of size that's offering health benefits to its own employees, then you can do that one of two ways. You can have a self-funded health plan and bear all the risk yourself, or you can pay premium to a health plan and they'll do it for you.
Right.
But I mean, if you're doing it yourself, then you have a couple of outlier claims. You have a premature baby that's born to an employee with a whole host of problems, or you have a couple of employees with a significant cancer diagnosis. I mean, those burdens on your health plan financing are going to be heavy. So if you're now going to do it for other people outside your own employees, you have to be able to bear that kind of expense, and it's just too much money for most places. I mean, I guess if you had like an Envision or some other entity that's got thousands of physicians as employees, you could probably do it, and they do it for their own employees. But to do it for third parties, bad idea.
Interesting. So what you're saying is scale is critical in these types of scenarios, and you simply don't have the scale if you're talking individual physician.
Right. It's risk pooling.
Yeah. Now let's flip that around. We spoke about individual physicians. What if we go the other way and we talk a little bit about Amazon and why Haven failed? What was the thought process? Again, you don't know any inside details as far as I know, but from a person who helps with these types of scenarios, what were they aiming for, and what caused it to go wrong, as best as you can tell?
Well, I mean, I think one of the things that caused it to go wrong was the hype that they jumped into it to start with. They set the bar so high, and anytime Amazon in particular does anything, the media rushes out and proclaims it the next huge best thing that's going to disrupt and reform the industry, and none of it has ever happened. It doesn't do that. With Haven, the original idea, although they didn't ever announce what its original idea was, once they hired a CEO and started building the platform out, the purpose was to provide an employee benefit plan for the three large companies that were included: Amazon, Berkshire, and JP Morgan Chase. I mean, that's 500 or 600 or 700,000 employees. It's probably maybe more than like 1 million employees. So that's a large employee benefit plan, and if it worked, then they could have possibly saved themselves a lot of money on their employee benefit costs.
Yeah,
that was what it was supposed to be, and then they were going to try to scale it out to offer it to third parties out there, whether or not that's CVS or Boeing or whatever entity out there, and they couldn't make it work.
So what part? I mean, it sounds like any other employer benefit plan, and you just sort of insourced the management. Why would it fail? I mean, you have tons of money to throw at the problem here. So it's not money, it's not experience. So what could have been part of the problem?
I think that it's very, very difficult to compete with entities out there that their sole focus is healthcare. Okay. Amazon is the Sears and Roebuck catalog of the 20th century, or 21st century, whatever century we're in right now. It's the Sears and Roebuck catalog. When I was a kid, I mean, the Sears and Roebuck catalog, this thick, came to the house. You could buy everything from bras to tractors to an entire house out of the Sears and Roebuck catalog. Now, you didn't pay a price per month for the for use of it, and the stuff didn't show up on your door the next day.
Right.
But it was basically the same thing. So Amazon, Jeff Bezos, God bless him and his bajillion dollars that he has, he figured out a way through logistics to assemble, what do they have? 5 million sellers on the thing. They've got 300 or 400 million active users and 100+ million, Amazon Prime members. They're all paying a monthly fee, to access all of the stuff that they sell on Amazon.
Right.
And then logistically, they get it from wherever it happens to be to you.
Yeah.
And the convenience is amazing. We have all learned that in the last year, where you could get anything dropped off at your front door through Amazon.
Yep.
But healthcare isn't the same thing. People don't like to buy their healthcare the way they buy razor blades. They don't trust it.
I don't know. And maybe I don't represent all people, but I obviously don't represent all people. But I kind of like the idea of being able to get my medicine dropped off, talk to my doctor on the phone, and never have to go to an office unless I'm really, really sick.
Okay, can I ask you a question?
Yeah, please.
Do you do that now?
I don't know how to, but I'd love to.
No, I mean, can you get medicines dropped off at your door?
Sure.
Okay. Can you talk to a physician on the phone?
Can I talk to a physician on the phone? As far as I know, no. I don't think I can.
Or through telehealth or WebMD?
I've done telehealth before.
Okay, so you can, and none of it has anything to do with Amazon.
But I'm trying to think through it. It's a really good argument. I like the concept of it, but in reality, do I actually do it? It's a great idea. So let me think through it.
The mousetrap exists already. That's the problem.
But it's an inconvenient mousetrap. In that, I'll tell you what I mean by
what's
that.
inconvenient about Express Scripts, for instance? When was
the
last?
fact that I have to reach out to Express Scripts to do it. What I like about the
As
Amazon
opposed to reaching out to Amazon to do it.
Well, here's the difference. With Amazon, I can theoretically, if they built that better mousetrap, it would be I call the Amazon doctor sends it to my Amazon pharmacy, the Amazon pharmacy delivers it to my door. All I've done in this whole thing is reached out to Amazon doctor. Right now, what I'd have to do is call my doctor, who would then reach out to a third-party payer, who would then reach out to a pharmacy, who would then reach out to a PBM, and then send it over to me. So those extra steps where I probably need to get involved, that friction is what makes me go. And to add to that, the fact that I'd have to pay for delivery in most cases is what makes me go, it's not a frictionless environment.
Do you not think that you pay for the delivery with Amazon?
But I'm already paying for Prime.
It's just built into the price.
But I'll take it because I'm not
so
that friction.
on this way, let's assume, and I'm just going to use an example. Let's say you had Humana.
Sure.
Take Humana. Sure. So you have Humana, you go to your physician that is contracted with Humana. They order a medication for you. It's called into your pharmacy. Mm-hmm. Or if you have such a plan, it'll be sent directly to Express Scripts. Right. If it's sent directly to Express Scripts, they mail it out to you. It shows up in a couple of days or in a day because they have overnight delivery as well. Mm-hmm. And you pay whatever your co-payment is, for that, the same way that you would with anybody else. And you've not had to contact anybody but just your physician.
But Amazon already has my details. And it's one more.
So does Humana.
I'll have to think through that. I love the challenge. I appreciate that.
Humana has all of that too.
But do they use it in the same way, or do they need to reauthorize it somehow?
But Amazon would be doing the same thing. It's just done where you don't see it.
But that's important.
See, that's one of the things that people don't trust Amazon or Google about. So remember it was a year ago when it was Google, I think it was Google, announced that they had some healthcare data sharing arrangement with a large health system. And everybody lost their minds over it because they didn't want Google having their health information. Now, they don't mind if Google owns every other thing about them, but they didn't want them to have their healthcare information. Amazon's running into the same problem because Amazon has one of the things that would make the Amazon experience better, maybe,
Mm-hmm.
is that Amazon can track basically everything that you do. If they join with, Apple or, Google, which has Android, then, they could track damn near everything that you do. It's the joke about the guy who was really upset and was whispering around his house, and his wife goes, "Why are you whispering?" He goes, "I think all of our appliances are spying on me." So what do you
Wait.
mean spying on you? They're spying on us. And she goes, "Don't you think that's funny and kind of silly?" And he goes, "Yeah." And he laughed, and his wife laughed, and Alexa laughed. You know, it's the same thing. They
Yeah.
know because you have given them the authorization by use of this, and
Right.
you're clicking on everything on Google and everything on your iPhone, and they have all of this information. They can mine all of that information, and they can go, we need to send Darshan some
Yep.
information on pre-diabetes because Darshan has bought donuts the
He did.
last three days of every week for the last 6 months. We need to make sure Darshan is aware that he may be doing X, Y, and Z.
Very fair.
People don't want Amazon to have that information. They're fine as far as its retail stuff, but they don't want the other part of it. Plus, Amazon is a logistics company.
Yeah.
They are not a risk pooling company. They are not betting to the tune of billions and billions of dollars on whether or not they can keep a given set of people healthy or not. They want to sell services, which they're very good at, and they want to, particularly in cloud computing and things like that. They want to sell tech, and they want to sell stuff.
Yeah.
And they're really good at selling stuff and services, but that's not the same thing as running a managed care company. PillPack. So they bought PillPack. PillPack was a mail order pharmacy, and everybody rushed out there and said it's going to change the whole way that the pharmacy system is done.
Yeah.
It did not.
It
It
did
will
not.
not. It is just a mail order pharmacy. That is all it is. And
Kenny, you got to come back because we got to talk about PillPack and what's happening there. Is it the same story as Haven, or is it something different? Because,
no, I think PillPack will work. I mean,
but it'll be
within its
just one
limited
thing.
thing, but I mean, it most of the things that Amazon is creating are services that are best used by the self-funded health plan industry. So if and have to be an employer of size, but
Yeah.
let's pick Boeing, they're up there,
Yeah.
in the Seattle area. So if it's Boeing, then they have a large number of employees they need to provide that to, Amazon Care, which is their newest thing, which is the telehealth part. They can bolt that on to as a benefit to someone's self-funded health plan. They get paid an administrative fee for it. The physicians, for corporate practice of medicine purposes, are actually employed by a different entity, but it's all controlled by Amazon. But I mean, you access an Amazon doctor through an Amazon platform to get telehealth services, and that can be sold to an employer plan group. They pay a fee for it. Boom. That kind of thing will work. It's not going to transform healthcare, but because those services are already out there. It's not a new mousetrap. It's not even a better mousetrap. It's just a mousetrap.
I guess that's what confuses me, and I think that there are. I guess when I saw the emergence of this concept, probably about 2017 or so it's been several years, I thought what Amazon would be able to do, and it hasn't done it, it's done a piss poor job of it, to be perfectly honest, was leverage um, some of the technologies that are out there to make a better mousetrap. For example, um, they have Alexa in my house. They have they might be sending me my pills. Sorry, mine's going off. But the response being, if you if they know that I'm taking the medication, them sending me a daily reminder, them reaching out saying, you know what, you haven't responded 3 days. Here's our physician reaching out to you, going, did you do anything? Those
those kind of tech things are certainly available, and they are being investigated by a number of entities, including the larger health plans that have obviously big investments in AI and insure tech and medical tech, digital health stuff. That are those type of things. It got slowed down because Alexa wasn't HIPAA compliant until late 2019, early 2020, so they couldn't do it before then. But now that Alexa can be made, HIPAA compliant, they can do that. And having that kind of tech in your house that can be hooked to a system that will then remind you at 9 o'clock every day, Darshan, have you taken your meds today?
Right.
Because while you may not forget that, an 80-year-old may.
Absolutely.
And they need to be taking their medication. And if they've got something in-house that they're familiar with, that's easy to use, that is going to remind them, that is a piece of a puzzle. That is a good thing. And with Alexa or with any of the other, that's the most popular version, obviously. But I mean, I think Google has one, and there's some others as well.
Apple with
that,
Siri.
You can add those technological advances to a wellness program, whether it's an individual wellness program or a large-scale wellness program, to remind people, get up and move around.
So I'm going to ask you a question that goes along with it. The last question, if you will, because I usually try to keep you for 20 minutes and I'm already at almost 40. But the question I have is, from a HIPAA perspective, it's always been, you can't share my data without my approval, without my consent. That was really the goal. And let's be honest, no one's reading these HIPAA forms because they're just too long and they're just really hard to read. What makes people, more specifically, and again, I'm picking on Amazon, but I imagine this applies to any retail seller, online seller. But what makes Amazon not go, you know what? I already own PillPack. I'm just going to put a form in front of you saying, do you agree to allow me to share your data from PillPack with the Amazon online store and vice versa, which will help you make better healthcare decisions. So that's the second box of donuts you want to buy, Darshan. Yeah, we're not going to send it to you because you haven't finished all your pills for diabetes yet, and your dose keeps going up.
Yeah, well, when that starts happening, then we're in real trouble.
We are, and we're not that far away though.
Because although that means the end should never justify the means.
Mm-hmm.
It doesn't justify it in cancel culture. It doesn't justify it in politicians not telling the truth. It doesn't justify it certainly in medical care, where we are going to substitute our position that we're not going to give you the donuts. Why? Because we've decided you can't eat the donuts because you're going to have diabetes if you eat another donut. That would cause a problem, and it should cause a problem. But in the process of having those type things available to you, the forms that you have to fill out for HIPAA versus the forms that you sign your life away at the bottom of the Apple agreement that no one has ever read. And there's that shirt that says, it's like arguing. This is very misogynistic. Sorry. It's like arguing with a woman, you're never going to get to the end, and you're just going to agree anyway. So at the end of the Apple agreement, that's 9,000 pages long, everybody just scales to the bottom and hits agree. They don't know what's in there. So you can't do that with HIPAA forms. HIPAA forms are regulated by the Department of Health and Human Services. They have to say certain things, and you have to knowingly sign it. It can't be a boilerplate, 50, 60 page thing where this is buried in the middle. That's been litigated before. You can't do it.
Let's be honest. We have enough lawyers who can spin that to go, you know what?
That one's been tried before and has already been overruled.
As in,
that
okay,
one's, yeah.
that's what I missed. Okay.
You're not going to be able to do that. Now, if you willingly
Yeah.
decide to give, you know, authorization for Amazon to share your healthcare information within the various things that it does that's
Yeah.
under its HIPAA,
Yeah.
contract, then you can do that.
That's what I meant.
That you wouldn't need to have it buried. I mean, people
That's what I
would,
mean.
do it. And it's particularly age-related people. Young people don't care.
Yeah.
When was the last time you saw a 20-year-old or a 25-year-old that was going to tell you, I don't want so and so knowing about my health information? Most of them could care less.
Which I think is fascinating, and that's a whole different discussion, because I feel like my generation, maybe a little bit younger than me, are the least careful with their privacy, but I feel like the generation after them, I think it's now called Generation Alpha, they're actually pretty privacy savvy. They're going, no, I want to be on Snap and not Instagram, where my data just disappears after, I don't know, 30 seconds, as opposed to Instagram, where it lives on forever. So maybe it's a generational thing, and the generation in the middle was the chasm, where we just didn't give a
Could
crap.
be.
Yeah.
I like having all my stuff in a paper file someplace where I can shred it. But I'm old, so.
Okay, Kenny, I'm gonna do a thing that I've done with all my guests, and people tend to love this. And by the way, you're always an incredible source of fascinating information, so thank you. But we're doing rapid fire questions. We have 5 questions I'm gonna ask you.
Okay.
And we'll go from there. What's the best compliment you've ever received?
That I knew what I was talking about.
Okay. How do you define success?
Personal happiness.
Very cool. If you were a superhero, what would your powers be?
Oh, I have a shirt that says, if I was a Jedi, I have a 100% chance of misusing the Force. You should never give me a superpower. Ever.
Well, that's why I want to know what you would do with it.
I'd probably ask for X-ray vision.
Okay. Not going to ask why, because
Don't.
I'm plausible deniability there. If you were going to build a 2020 Mount Rushmore, who would be the first person on it and why?
A 2020 version of Mount Rushmore. Tom Brady.
Wow, why Tom Brady?
Well, because he's got 7 rings, right?
Okay. You know what? You win. You're right. I'm not even. Yeah, I'm with you.
I
love
could
your
say
answer.
Trump, but I mean,
he'd love you for that.
But I didn't like Trump.
Okay.
I liked his policies. I just didn't like him.
Fair enough. And who do you trust completely and why?
No one. Because we're
what
human.
About Amazon, though?
I don't trust anyone completely because we're human, and humans are fallible.
Okay.
There are 2 things that my wife doesn't know about me. Only 2. She doesn't know how much life insurance. She does not know how much life insurance we have, and she does not know the combination to the gun safe.
Interesting.
Those are the only 2 things, because I don't want her to use one to access the other. So, and we've been married for almost 30 years,
right.
And this is, I don't trust anybody completely.
Okay. I can work with this. So, Kenny, here's a question. Based on our discussion, what is one question you'd like the audience to answer for us in the comments?
I would love the audience to answer, are they willing to have a retail giant provide their health care?
Ooh, that's a good question. Okay.
Because the best one that's this is right down your alley. The one that's closest is CVS.
Oh, see, when I thought retail giant, I was thinking Amazon, but that's not the direction you went.
CVS, retail
You're
stores,
right.
there's
You're right.
thousands and thousands of them, and
Yeah.
they have minute clinics.
Yep.
They
They
give
do.
vaccine. I'm going to one this afternoon for my second shot.
There you
I
go.
mean,
Okay.
and it's a retail pharmacy. They sell Reese's Pieces and drugs. You
Yeah.
know, you can buy food in them now. I mean, you know, you can get alcohol in them now. But I mean, that's a real question. Do you trust a retail giant like an Amazon to provide your healthcare?
Which is really an interesting question because I have my CVS card or whatever it is. My question is, knowing what prescriptions they give me, can CVS decide tomorrow that they are going to charge me an extra $2 for every Mars bar I buy because they really want to disincentivize that for me? Why not?
They could, but then you just go to Walgreens to get your Mars bar.
Very, very
or
true.
Walmart.
Or I might just walk away and I might ignore it because it's an impulse buy.
I don't know. Mars bars are Mars bars. You might, you know, since these places are available all over the place. I mean, that's the other. I think that is one of the biggest hurdles. Let's skip for a moment the legal and regulatory hurdles that they will encounter. So this Amazon Care, currently is only available as an actual thing to Amazon employees in Washington State.
Right.
Because the entity that they have providing the care is only licensed in Washington State.
Right.
So, you know, until they're available other places, you can sell the platform, which is what they're doing, you know, to other entities, but you have to get your own component parts to provide the actual care because Amazon Care is run by Care Medical. Well, it used to be Oasis Medical, now it's Care Medical, but it's only in Washington State. So let's skip the regulatory and licensing issues. You'd have to get over the hurdle of people not wanting to have their medical care sold to them by Walmart or Amazon or, you know, and I don't think most people want that.
See, I don't think most people care. Hell, I would go one step further and say I'd be okay with it if I could because that means that I can reach someone if I have a question, which I feel like I cannot do it emotionally. I feel like most of my insurance companies are phone calls away, and then I have to go through this rigmarole of different conversations to have, as opposed to walking into the neighborhood CVS and going, "I need drugs. Help me figure this out." So it's an interesting concept, one we got to explore separately. But okay, I'm kind of trying to do a summary here. During this podcast, we landed up talking about physician-owned plans. We talked a little bit about the use of premium dollars, and we talked about what would Amazon managed care look like, or more appropriately, retail managed care, and what could that mean? We talked about your practice. We talked about what is a managed care practice and the quote unquote big bucket of managed care. Did I miss anything, Kenny? HIPAA maybe a little bit.
We said Canadians were nice people.
We did say Canadians.
We mentioned, you know, the goat got his mention.
We did. You
know, so
fair enough.
We can talk about Alabama football, one of my favorite topics.
Here's the thing you should know about me, Kenny. I am pitifully bad when it comes to anything sports. So it's embarrassing.
You're in a bad town for that.
I know. I really am in a bad
town.
Talk
about rabid fans.
I know.
You live in Philly.
I know. I can't even.
Where they set their own when they set their city on fire.
I know. To quote the ex-president, bad things happen here.
Yes.
Nothing in this podcast should be construed as legal or clinical advice of any kind. It is intended for educational and entertainment purposes only. For those of you who missed it, Kenny, where can they reach you?
They can reach me on LinkedIn under Kenneth White. They can reach me at kenneth.white@willistowerswatson.com. I would love it to be WTW, but I think that's Weight Watchers. So We can't use it. Kenneth.white at willistowerswatson.com is the easiest way, or on LinkedIn.
Perfect. If you like this podcast, please leave a comment, please subscribe. You can find me at DarshanTalks on Twitter, or just go to our website at DarshanTalks.com. Thanks again, Kenny.
Thanks, buddy. Hopefully we get to see each other in person soon.
Soon. I'm looking forward to it.